So let's get back to specifically what do you do for monitoring and dose reduction? So how do you monitor blood counts and chemistries? Sort of some specific things you do?
Sure. I mean, we follow the kind of the rules of the prescription information in the ramp-up dose. We do early, the first day of the new dose in the 20 and the 50. After that, obviously in the 100, 200, 400 is easier. And after that, as far as the patient don't have neutropenia, we can really extend the period of time for which we see the patient. Neutropenia, you are right, that is one of the common reasons why we should really sometimes stop the drug, use growth factor, or even really lower the dose, really from 400 to 300 or 200. And very, very interestingly, it happened to me in a few times. This happened during the period where you really coincide with the monoclonal. And for the people who are not familiar, the monoclonal, the obinutuzumab, is given for 6 months. So there's another extra 6 months the patient only take Venetoclax, right? So you see really a better tolerance in terms of neutropenia as soon as the monoclonal is out of the picture, and it's something that obviously needs to be followed closely.
Okay, you brought it up, so I need you to explain something to me that I'm still not understanding.
Sure.
Rituximab, well, especially rituximab, there's this idiopathic or neutropenia that you can sometimes see. Why?
Absolutely. It's something that is fascinating me for many, many years. Why a monoclonal antibody really can produce neutropenia? And I have to tell you, I went through the literature more and more, and the best thing I can really see that when you really deplete B cells, it's a very, very subtle relation between B cells and neutrophils that not many people understand, and I personally do not understand.
Okay, I'm not alone then. Good, I'm
glad
to hear that.
But you really hit the point, and we really go to any of the drugs that we are using as target drugs. There are target drugs that they are not really hitting the bone marrow. They're targeting the peripheral blood. So as soon as we really deplete the B cell compartment, neutropenia happen. And as you know, happen classically with Rituxan, right? It's a technically peripheral neutropenia because we know that these neutrophils are in the bone marrow, but with obinutuzumab happen even more. Yeah. And so I think it's fascinating, happen with the BTK inhibitors, happen with Venetoclax. So I think it's very, very interesting, and there is some publication, scientific publication, that they try to really understand this relation between neutrophils and how B cells can really collaborate to really keep these neutrophils around.
Well, it tends to be a late phenomenon with the rituximab. It's not in the first dose or two. So this hypothesis that's related to the population of B cells seems to make some sense.
Yeah.
Well, that's interesting. Okay, so you've already alluded to the ramp up with it. When you use rituximab, do you delay it, or do you, like obinutuzumab, you start it now early?
I mean, when I use a Rituxan, I try to use the same regimen. I try to use the Rituxan first. I don't really follow the recommendation of the Murano trial where they were used at the same time. I really recommend to my colleagues in the community to use the monoclonal antibody of their choice, because some people may be more familiar with Rituxan. As we know, obinutuzumab is a superior antibody, but it's slightly more complicated to really manage infusion reaction. So whatever antibody they want to use, for sure in the second line is Rituxan, in the front line obinutuzumab, and really after that start the ramp-up dose after 2-3 doses of this monoclonal.
Okay. You already alluded to the problem with drug-drug interactions and CYP3A4 inhibitors, so I assume that it's the same avoiding grapefruits and
absolutely.
Seville oranges and star fruit if you can find them in your grocer,
that's
right?
Exactly correct.
Okay.
Exactly
but any other instructions that you give your patient about dosing with food, without food?
I do not have any recommendation, and most of the time I ask them to really check at the same time of the day. But I think it's very, very important to go deeply about the list of medication patients are taking, because again, you will be surprised, and sometimes you may have like a one moderate and one mild inhibitor that may really be more cautious about how you do the ramp-up dose. But again, going through the list, classical azoles, posaconazole, voriconazole, fluconazole, verapamil, diltiazems, even ciprofloxacin, things that we are very, very used to really seeing patients of this age, or even, for example, when the patient have an infection, which is the antibiotic we should really use in certain point. I think it's important to keep in mind, and then obviously we work with our pharmacists to make sure that our patients are safe.